Yeah, the third day. Today we are going to have a workshop, and in this workshop we'll give a scenario. As we move on, you can answer the questions according to whatever you say. We'll do here, right? Any questions? Okay, go on.
So we have this scenario. We have a 42-year-old male with no significant medical history. He had developed chest pain, which is radiating to the left shoulder and nausea. His ECG revealed STMI. He was taken to the hospital, but before we could take him to the lab, the patient had a VT, which is unstable VT. So he underwent emergency angioplasty, was shifted to ICU with elective intubation. He was on norepinephrine with 10 mics per minute, epinephrine with 5 mics, and further also increased the dosage. His ABG revealed high metabolic acidosis with very high lactate level. So what would you think about this patient? What would you consider next?
How will you proceed further? Just relax, like what you are doing now. Okay. Like usually, there are quite a significant amount of trials now. IABP can support for around say 0.5 to 1 liter per minute of blood flow. So if it is going to be more than that, like with a high amount of inotropes, IABP may not be helpful. If you don't have a facility of ECMO or something like that, you can try IABP for some time as a bridge graph, but most of these patients will end up in ECMO. If it is going to be a severe LV dysfunction. If it is going to mild or moderate, requiring say only 5 ml of NORAD or something like that, we can play with the IABP, right? Okay. Next one. So any, you know what is a VA ECMO and VV ECMO now? Do you have any questions? You don't know about it, or you want some explanation on that?
In this case, it will be a VA ECMO.
Yeah. So VA ECMO is to support the heart. So VV ECMO is only, it can support only the lungs, but VA ECMO can support the heart and the lungs, right? So a choice of cannulation?
In an emergency setup, I think femoral vein and femoral artery.
Yeah, that is the best choice. Femoral artery and femoral vein, easily accessible. So we can cannulate the femoral artery and the femoral vein. Cannula size, the patient weighs around say 60 kg. Maybe a standard cannulation for an adult is for arterial, it can be around 19 French, and venous can be 23 French, right? Yeah, proceed. Ideally, it is better to do a cannulation with ultrasound guided cannulation is better, because when you blindly puncture, there is chance of injury to the posterior wall and also surrounding vessels, which can damage. And most of the people, if you ever do like that in normal people, it may heal. But these patients are going to be on anticoagulation, so they will have retroperitoneal hematoma and blood collection and bleeding and blood loss and all in the post-op. So for as far as ECMO is concerned, better do ultrasound guided puncture, so that only one puncture in the anterior wall should be able to, we should be able to introduce the cannula, right? Please play. This ECMO, this echo should be there. Echo image on the screen, please. Which side you want to insert the vein and which side you want to insert the artery? To the audience. Look at it. So is there any side preference, or you don't mind any side? I think there you are able to see the filter. Medial one is the vein or the artery? No idea. Vein, yeah. So lateral is artery. Which one you want to cannulate on the right side? Vein or the artery? Ideally the vein, because it is into, we can negotiate the cannula easily to the heart from the right side. What is it? Straight course, of course. Very good. So we prefer the vein on the right side and artery on the left side. Why can't we put both on the same side? Yeah, maybe like ideally, like if you're going to cannulate the artery, there will be compromised blood flow to the lower limb, right? So with that compromised blood flow, if you're going to compromise on the venous congestion also, then the chance of ischemia to the lower limb is high. We don't want that to happen, so we are doing it. But in emergency situation, whatever cannula side you get, you put it. That is a different issue. In the elective case, better vein on the right hand side and the artery on the left hand side. So let's keep the vein the center. You can see the needle in the vein of this running. Get a syringe. So we got it. Increase the pressure. You can see the guide wire in the vein. Then you have to increase your pressure point. So it should be serially dilated. Next dilator. We have various stages of dilator, like 8 French, 10 French, 12 French. The cannula size, what you're going to do, you're going to introduce is somewhere around 19 French, means it's better to dilate up to around 20 French. And then so that our cannula will go in very smoothly. So this is 16 size. Our idea is to dilate the skin, subcutaneous tissue, and the vein hole, the point of entry. So up to here, if you introduce, that's fine. So you not introduce the whole length and then injure the posterior wall, right? Before introducing the cannula, measure the cannula so that it should be in the RA. Usually we'll keep it at the RA IVC junction. That usually corresponds to the Ziphisternum. So when you keep this cannula, not the dilated tip, it should be the cannula. This one. So that should be corresponding to the Ziphisternum. So if you keep like that, here the length is 35 centimeter. So up to 35 centimeter, I'll be pushing it in. Normally, this is very important for VV cannulation because to avoid the recirculation. In VA, it doesn't matter. If at all you're going to convert the VA to VAV, this will be useful. So ideally, to position itself in the let's lock this cannula to the dilator. So it will go in smoothly. You have to keep it till 35. Then you can remove this. Clamp it after filling the tube. So your venous cannulation is over. Now let us go for the arterial cannulation. For arterial cannulation, what we are choosing is somewhere around, say, 19 French. That corresponds to how many millimeter diameter? Usually the cannula size divided by 3 will give you the answer. So 6 point something. So it will be around 6 millimeter in diameter. The femoral artery itself, with a vasopressor or something like 10, that itself will be a 6 millimeter. So if you're going to place the cannula, the whole lumen will be blocked. So if that is going to get blocked, then the chance of limb ischemia is too high. So first place the distal perfusion cannula, then go for the retrograde cannula. That is a normal routine cannula. If you want to place the cannula first, like a proper cannulation, veno arterial cannula first, then you can't find the distal perfusion cannula because that is going to block the flow. So first place the guide wire to the distal perfusion cannula, then proceed with the arterial cannulation, then you can put the distal perfusion. That's what we are going to do here. Any questions? Are you able to understand? Come on. Gossip. So as usual, the medial one is the artery. Can you project the ultrasonogram? The main screen. The mannequin can come on the left side. The echo have to come on the right side. That's what I told. Where is that person? His name is Ray. Ray? Yeah. Mannequin should be on the left side. Echo on the right side. You can see the pulsation also there. Artery. Can you show it side by side? Ray, can you do it? Then you take this out. No, take this out. So you can see the guide wire. The white one is a guide wire that is there in the artery. What is it?
Now you can switch to.
This is the distal perfusion cannula where you have a port through which the blood can be given, right? So, DRS. So we are dearing the distal perfusion cannula, then the syringe, or else the needle, puncture needle. Look. Can I have a gauze piece? is punctured. You can see the blood flowing from the femoral artery. You can take off the echo. So now he's dilating the vessel. Here, no need to measure the length. You can push it fully so that it is going to lie in the common femoral, common iliac artery. Like there also, you need to hold these things together, or else there will be a step up. So these things to be held together. And this also needs to be removed. Of course, like after de-airing, you can clamp it. So as soon as you do it, take a purse string and fix the cannula. Otherwise, while you are concentrating on the other things, the cannula may come out, especially the return cannula, where it is going to flow under very high pressure. What is the return cannula?
Sir, asking was common femoral or superficial femoral?
What we are
Yeah, function for the arterial.
like common femoral and superficial, slight difference may be there because it can be slightly higher up or lower up to the inguinal ligament. So usually like to keep it below the inguinal ligament. If you are able to get the common femoral below the inguinal ligament, go for it. If the common femoral is going to like it is going to be high up branch to the common femoral is going to branch to superficial femoral artery and deep profunda at the higher up than the inguinal ligament, don't go for that because you're going to puncture that. Something happens with accessing that is very difficult and it can go for a retrofetal hematoma. So stay around 2 or 3 centimeters below the inguinal ligament. Whatever artery you get there, hit it. Aim for common femoral, but don't go for it, right? Once everything is taken, the circuit is primed and kept ready. So we are going to connect this to here. Artery. Yeah, tubing clamp is also. Yeah. Okay. De-airing of the cannula, you mean, or the circuit? Circuit is challenging for me also. It will be taking care of the perfusionists usually. Like they are used to the cardiopulmonary bypass sites. So they usually run the pump and then de-air the circuit. The priming the circuit of the ECMO is quite different from the normal routine cardiopulmonary bypass. That too in emergency means that should have a lot of training. Each ECMO circuit differs by itself. Like a MAC circuit is not same as MEDOX. It is not same as a Centimac pump. So each one differs. And whichever your profession is comfortable, you have to do it and prime it and keep it ready. Yeah. De-air it. Yeah. Yes, yes. Yeah. So that is a topic by itself, sir. De-airing the circuit needs something, especially the oxygenator. The long-standing oxygenator is difficult to de-air when compared to the routine oxygenator, what we use in the routine cardiopulmonary bypass machine. There are a lot of air vent ports in the oxygenator where you can open up and de-air it. If you want your professionals, you can give a call to Emmanuel. He will be able to teach you. The venous cannula he is connecting. The venous cannula is marked by the blue line in the venous line. You can see the red mark here. There is the arterial line. The circuit is connected. Here, unlike the venous cannula, you have a distal perfusion port here. There is a port, a side port here. So this side port is connected to the distal perfusion cannula. So the blood from here can move to the distal perfusion cannula. So blood here will move towards the heart, and blood to here will move towards the foot, right? So that the lower limb perfusion is not compromised. Yeah, we are releasing the clamp. We establish the flow. So start with a low flow and gradually increase the RPM. The flow also will be increased. Ideally, we'll keep around 3 liters flow to start with, and then take it forward. And because there's a mannequin, we have introduced only say 17 and 15, and we are going to have only around a lesser flow. But normally for a 60 kg adult, we'll be keeping around 3 liters per minute flow and take it forward. Then we'll record the map. Map will be aiming at say 60. And then when the urine output and lactate are fine, we'll maintain like that. Okay. Any questions or doubts till now?
Because we have inserted the distal perfusion cannula, the size of distal perfusion cannula is small, very small. So is it sufficient for the distal limb?
Yeah. So the cannula what we have placed is 8 French.
Okay.
So 8 French cannula up to around 250 or 300 ml of per minute should be okay for the distal perfusion.
So
Also, we will not leave like that, and we'll monitor the distal perfusion flow every say hour or so. We'll be recording the Doppler signals. It will not be a triphasic flow, it will be a monophasic flow, and that will be recorded every hour, and then we'll be informed.
So you assess the distal limb vessels flow. So is there any device available which can check the flow from the cannula? How much blood is going to the limbs?
Yeah, like there are flow probe, but it is difficult to get in India. We are using the Centrimag flow probe to calculate that. But there is not only 250 ml of flow that we can easily monitor by having a saturation probe or a Doppler probe. Using the Doppler flow, we can easily identify the distal perfusion. If we monitor every hour, we can identify early ischemia. So distal perfusion cannula also is a trick. Like what we have demonstrated here is a PA sheath, which is very plastic and it can be molded. But if you're going to have a wire reinforced distal perfusion cannula, which is actually have to be, show me the wire reinforced. On PA sheet. This is the distal perfusion cannula. Actually, you need to put it. So you can see that it's a wire reinforced cannula. Can you see it? And chance of kinking is very less. Also, it is longer. In obese patients, it can easily access the femoral artery. This is a PA sheath, what usually we are putting. So here it's a plastic material, so it can easily cling and the flow can be blocked. So better to go for wire reinforced distal perfusion cannula. The chance of blockage is very less. Yeah, so that is the one we first place. Then only we'll put the proper arterial cannula. Distal perfusion. Because once you place the normal arterial cannula, you'll not be able to see the pulsation and other things down. And also the artery also will go for narrowing. Cannulating is very difficult. So first to put the distal perfusion cannula and then go for the arterial cannula. The distal perfusion cannula where the site of entry should be always distal to the routine cannula. So it will not disturb the proximal arterial cannulation. This and all can be done only in elective cases. In case of emergency or ECPR, just go for proximal and worry about the distal later. Like it can be, we can the interventional radiologist, or else we can do by open technique later. Can you give the mic to him? So like we always 100% you put the distal perfusion cannula for all patients. If you're going to go for vena arterial ECMO,
just this ECMO.
Yeah.
Routinely, how frequently you go for the percutaneous everything?
Percutaneous for almost all cases, unless otherwise the artery is going to be diseased. That too, out of say close to 300 cases, we have done by open technique only 10. Remaining 290 cases we could do by only percutaneous. So that 10 is also some of them are diseased artery. So when you place it, the chance of dissection is very high. So you open it and then take a graft. You stitch a graft to that and then place the cannula to the graft. So that the both way the perfusion can happen. To do the side anastomosis and give the flow through the graft, can go proximal and distally. Like that, especially if the artery is diseased.
In that case, you doesn't need the distal.
No need of distal perfusion cannula. It's going to be a side port and it will give the flow on both directions. Graft size what we are going to use 8 French. 8 French. 8 French can create easily this 8 size graft. So you can easily take this 9 French tube or 21 French also it will take. Right? So, or else in ECPR, where they're doing the massage, and we are not able to get the artery by, say, puncture. It is very difficult. Not able to get the ultrasound emission quickly. At the time, you open and place it, the artery, and then get the flow, and then stabilize the patient and shift him to the OT. There, you repair the thing and place a distal perfusion cannula and get it out. So quickly establish the flow. Remaining thing worry in the OT. That's all. Distal perfusion cannula will put it in the OT. In those two scenarios only we do the open technique, but on the otherwise all the cases we do only the percutaneous technique. Okay.
Pressure is low.
Yeah.
In that situation, your percutaneous puncture is that possible?
That's what I'm saying. In the emergency situation where the blood flow is very less, and also we don't have ultrasound emission down by side and other things, we go for open technique. Open it, identify the vessel, and put it, and establish the flow. Then we'll worry for the distal perfusion cannula, things like that. Just establish the flow by open technique. So in those are two scenarios.
It will take at least half an hour to calculate and start the perfusion.
Like usually for this arterial cannulation and other things and all, we take 15 minutes or so. Either open or subcutaneous, especially in the emergency. Like the whole our team will go there. Both cannula, both groin will be exposed if they are not able to. First, if the ultrasound machine is in the bedside, both team will be involved in putting the vessel. Whichever gets the first will connect the vessel. Or else if they are not able to do so, then the surgeon will jump in and open the artery and then cannulate it. Between 15 to 20 minutes, we'll be able to access the vessels. So our ECPR kit team itself contains the surgical instruments also. If needed, that will be there. The huge, what is it, a football bag or tennis bag, what we are having, cricket bag. It's a cricket bag, the whole huge cricket bag. It contains all the necessary things, whatever is needed for us, for especially in ECPR. Okay.
Percutaneous for angioplasties we do, right? So venous puncture may be a little more difficult, but arterial puncture we can get.
But
on
in
CT.
cath lab, you have the fluoroscopy guided, so you
Yeah.
can do it much faster. Yes, you can see it and do it much faster.
Depends on the situation, sir. Wherever it's there. Our idea is to get it there. Whatever way it's better. Better to get his percutaneous because chance of bleeding post-op is very less. You want to open it, chance of bleeding is very high. So when you open the patient and cannulate it, we just close it in the bedside, but get to the theater and then properly expose and cauterize the vessels and other things. Place a distal perfusion cannula and then get him out. So that will avoid the post-op bleeding and hematoma complications. Yeah, proceed. Now we establish the flow. The patient is stable and PPT.
So we have established a flow for this patient. We have put on veno-arterial ECMO. As Saha has mentioned, we also has established the distal perfusion cannula for the antegrade flow rate. So we have a scenario now. The patient has been initiated on ECMO, but still hypoxic. We could find that the saturation has decreased from 91 to 87. And we are now on day 3 of ECMO, veno-arterial ECMO.
For all peripheral vena ECMO, you are supposed to monitor the saturation only on the right upper limb. Right? No.
Because of north-south syndrome.
Yeah, the Harlequin syndrome, other things. So always it is recommended to monitor the saturation in the right upper limb, right? So how will you differentiate between a problem in the lung or in the oxygenator as a cause instead of Harlequin syndrome? What is Harlequin syndrome? Any idea? Yeah, upper part of the body will be blue and lower part of the body will be bright red. Okay, go for the Harlequin video. So in this artery, this you have a pointer with you. Pointer is there. Venous cannula, we are arterial cannula we are inserting here is going up. Harlequin syndrome can happen only in VA ECMO and also with diseased lung. These are the two criteria have to be there for Harlequin syndrome. So patient should be in peripheral VA ECMO and patient should have a bad lung, right? So when the artery is given here, it is going up to there. And the heart is not pumping now. As it moves on, if the heart pumps the blood, and also if the lung is bad, like not able to oxygenate well, then the blood, whatever from the lung, will enter the heart and that will be ejected out. What is the first artery of the first branch of the aorta? Yeah, coronaries are the first branch of the aorta. That is going to receive a impure blood. The heart recovery will be delayed. So here you can see the heart started ejecting. So you can see a blue blood here. So whatever coming through the lungs, because of the lung disease, it is not getting oxygenated. So there is a mixture of blood here. The blue blood is coming from here. The bright red blood is coming from here. And both are getting mixed in this. So that is marked by a mixing cloud there. As the ejection increases, the mixing cloud will move forward, move distally. So the mixing cloud is now there. As the heart ejects much and more, so this mixing cloud will move down. So the impure blood can reach up to the, say, innominate artery, and it can go up to the right common carotid artery. And when the mixing blood is going to be there between, say, your left subclavian artery and the left internal carotid artery, then both sides of the blood supply of the brain will be with impure blood. That can affect the patient, and he will go for hypoxic encephalopathy. So this is the reason why we are monitoring the saturation in the right upper limb. you monitor the saturation in the left upper limb, that can be normal because of blood flow from the, distal retrograde blood flow from the ECMO. But this blood can be here. So when the mixing cloud is between the internal carotid artery and the left subclavian artery, here when the heart ejects and the mixing cloud varies depending on the ejection of the heart. It ejects more, then this mixing cloud will move away. If it ejects less, the mixing cloud will be close to the heart. So whatever is said and done, it is better to monitor the right upper limb to make sure the blood to the brain receives the blood to the brain is the saturation of the blood to the brain is somewhere around say more than 70%. If it's going to be less than 70%, chance of hypoxic encephalopathy is very high. You able to understand what is Harlequin syndrome? So when you see a saturation like of say 70 or 80, then you have to suspect Harlequin. Another possibility is the pump oxygenator. Other things can fail, like oxygen saturation or FA out on the ECMO can be low, or there may be some problem in the post membrane. So better to do the post membrane gas or monitor the saturation in the left upper limb. If both are say one is higher and one is lower, then that confirms a Harlequin syndrome. Okay. So just because saturation is bad, don't jump to the conclusion that there is a Harlequin syndrome. Mere fact that there may be a saturation and poor saturation in the post membrane gas itself can produce this low saturation all over the body. So better to monitor the saturation on the other side and take it forward. Yeah, patient is ventilated. Still this happens because most of the cardiogenic shock patients will have pulmonary edema. So pulmonary edema means there will be a drop in saturation. There will be sometimes significant drop in the saturation. There is a significant drop in the saturation, these kind of things will happen. So now we have diagnosed that patient is having a Harlequin syndrome. How are we going to manage that? So it is like a management of a pulmonary edema. How we manage a pulmonary edema? Normal, our 4 Ds, they will say, the decubitus, then diet, diuretics, drugs, 4 Ds. Decubitus, diet, diuretics, drugs. So here decubitus means you can raise the position of the cot, like increase the head end to around say 30 degree or 45 degree. That can get the diaphragm down and increase the lung compliance and then move on. And so next is diet. We're not worried about the diet here because patient is in shock. Third is drugs. I give the Lasix and other things to achieve a negative balance, and diuretics, like achieve a negative balance. Or else, if the urine output is not there, don't hesitate to place the CRRT, which is a temporary dialysis machine that can be connected to the ECMO machine itself. You do not put a separate line to the patient and cause more complications. So we can connect the CRRT machine to the ECMO and dry him out. If you dry him out also, the lung can improve. And finally, the drugs, like whatever drugs you can give to support the heart and like nebulization, things like that, and treat the cause for the pulmonary edema. If the pulmonary edema is not going to get treated, then we have to worry about the next thing. So sometimes the dobutamine will cause the ejection of the heart better, and then LV-EDP can be reduced, and then you can get rid of the pulmonary edema. Sometimes the mere fact that your flow adjustment also can reduce it. More amount of flow, the afterload can be more for the heart. The heart have to pump against a higher pressure. So that can also be a problem. If you reduce the flow, then the pulmonary edema chance can also can also be reduced. So in spite of all these things, if the patient is not going to improve the saturation, then the option is VAV ECMO, where we place another cannula in the neck and convert the VA to VAV ECMO. It is a combination of veno-arterial and veno-venous. Okay, any questions? So now we are going to cannulate the right jugular vein and then connect to the return limb, that is return limb of the ECMO circuit. So the pure blood will go to the neck and also left femoral artery. There's a guide in the vein. As usual, the serially dilate and then insert the cannula. Here, the cannula size, what we are going to introduce is somewhere around 17 French. This is only to give some oxygenated blood. So whatever blood is sucked from the venous side will be sucked through to the ECMO machine. It will be like partially distributed between the left femoral artery and the right interjugular vein. Here also, before introduction, we will measure the cannula from the point of entry to the angle of Louis. The angle of Louis is roughly corresponds to the RA SVC junction. So if you're going to introduce too much in, then there will be a recirculation. The distance between the tip of the cannula in the SVC and the IVC should be at least 10 centimeters. Otherwise, there will be a recirculation, and we will be managing the recirculation. So keep the lower cannula tip at the level of xiphisternum, upper cannula tip at the level of angle of Louis. Needs a proper planning. So they are taking a Y connector from the return cannula One limb is going to go for the left femoral artery, another limb is going to go for the right interjugular vein. So do you anticipate any problem here? Giving the flow to a venous system and giving a flow to the arterial system, to which the blood flow will be more? To the venous system or to the arterial system? Because one is connected to the arterial system and one is connected to the venous system, in which the pressure will be high. Artery or vein? Obviously, the arterial pressure will be more than the venous system. So wherever the pressure is low, the blood flow to that system will be more. So after converting the VAV, if you are going to keep a flow of, say, example, 4 liters, the flow predominantly go to the venous system than to the arterial system. Very purpose for initiation of the ECMO is to have a VA ECMO. So we want to support the heart. We want to partially support the lungs, but most of them will be supporting the lungs than the heart. So in this situation, what we have to do is we have to put something called a tube occluder to control the flow in the venous system. Otherwise, most of the flow will be going to the venous system, not the arterial system, which we don't want. Just a minute. So this is the return limb. So it is going here, and we are having a Y there. This limb is going to the femoral artery, left femoral artery, and this limb is going towards the right interjugular vein. We're going to keep like this. Most of the blood is going to go to the SVC, and blood flow in the lower limb is going to be, or else the artery system is going to be down and pressure and map will fall. So we're going to place a tube occluder in the venous system, venous limb of the return cannula, and occlude it. Now the question is how much to occlude. Just to keep the saturation in the right upper limb above 85%, you have to occlude that. Mostly around 1 liter flow in the jugular venous system can do this trick. So if you're going to keep around say 4 liters, 1 liter will be going to the venous system, another 3 liters will be going to the arterial system. Okay? Able to understand? Nicely sleeping here. Okay.
I have one question here. So, because as you mentioned that for to suspect a Harlequin, the saturation should be around 80, but in that
70 or less than 70.
less than 70. Okay.
So then only we'll initiate the VAV, because it's an invasive test. We'll do all the corrections, whatever I said. If you are not able to get it close to 80, then we'll place this thing. So we aim for 85% saturation.
In your example, you gave that the saturation dropped from 93 to 81%, I think.
Yeah.
Yeah. So,
81. Saturation is dropping. So we'll monitor like that. 81 is also not a very great thing. We have to suspect Harlequin at that time. So manage it, whatever thing, medically, non-interventional thing, you manage it. In spite of that, it's going to drop to 70% or less than 70%. You place the veno arterial VAV ECMO. Otherwise, it is not needed.
So more than 85% is okay.
Yeah. So more than 80 itself is okay, but more than 85% it's to lie on the safer side. That's all. Better to keep the arterial line is also on the right radial artery, so that we can actually take the blood and do an ABG and prove that the saturation is all right, rather than believing on the saturation probe alone.
This jugular venous line is a drainage line or it is a perfusion line?
Return line.
Return line is a pure blood line. Arterial return line. Return line is a line that comes out of the ECMO. So purified blood. Drainage line is a line which goes to the ECMO, which is the impure blood.
So it is a return line.
Return line.
Like
That-
arterial cannula.
Right arterial cannula. So arterial pressure, whatever we are giving, we are going to give through the venous side also. So only I said
Some of the blood is are going to artery, some of it is going to
vein.
vein.
Yeah. That's what we described the Y connector in the arterial system. One is going to there is return cannula, one is going to the arterial system, and one is going to the venous system. So if you don't put the tube occluder, most of the blood will go to the venous system because there is a low pressure chamber. So if the venous system is going to receive around 3 liters of blood, and arterial system is going to receive only 1 liter of blood, then your map and other things will fall. Very purpose of VA ECMO will not be solved. So you have to put the tube occluder to maintain a saturation of around 85%, and then go for the this one. Remaining blood can go through the arterial system, and you can maintain the map.
internal jugular vein, you connect it to the femoral artery.
The return limb. We'll not say the femoral artery or something, the return limb. The femoral artery only.
Yeah.
The femoral artery and the IJV goes and connect as a Y.
Yeah. Some,
And next, put the PowerPoint. Pointer. I think this image will be clearing your doubts. So this is the ECMO circuit. We want the PPT. So this is the ECMO circuit. So blood is drained to the machine. Pump and that goes to the oxygenator, that the pure blood comes from here. And we put a white connector here. And this limb will go to the femoral artery. And this limb will go to the jugular vein. So here we put the tubing clamp or tube occluder to adjust the flow. Whatever necessary flow can be there. There are a flow rate also can be monitored. And we can adjust it. But our aim is to keep the saturation more than 85%. The venous ECMO also, we aim for a saturation of 80%. To be on the safer side, we maintain somewhere around 85%. So the same principle is as well the this saturation more than 70, the brain will escape. So better to be on the safer side, we'll keep at 85. That's all. So now the saturation is okay. Patient is stable, and we have to wait for the recovery. So in Harlequin syndrome, there are certain things. LV have to eject. Then only the Harlequin syndrome can happen. Otherwise, whatever blood we are going to give is going to reach the aortic root, and the Harlequin will not happen. So LV have to eject, and lung function should be bad. So that we need to monitor. The saturation probe should be on the right always to check whether it's a Harlequin syndrome or problem in the saturation of the pump itself. We can place something in the left also to prove that there is a differential saturation. And points to consider are LV dysfunction and distension of echo by echo, and impaired lung function we need to prove, like can auscultate or take a X-ray and then take it forward. And if you keep a negative balance, chance of improvement in the oxygenation is better. And also the titrate the ventilator setting accordingly. Like in pulmonary edema, what we do, we keep a higher peak airway pressure or PEEP to give more oxygenation. That and all you can try. If in spite of that, if you're not able to achieve the thing, then you go for the VAV ECMO. Next slide.
So how frequently it is needed practically?
This one, very rare. Like we would have placed only close to say VA ECMO. We would have placed around 75. Out of that, only around 8 cases, I think so. We place this VAV. It is very rare situation. Most of the case we'll be able to manage with the medications, the diuretics, or with ventilator parameter adjustment we can make. Once the diuretics, you should be very aggressive on the fluid restriction and diuresis. Once there is a negative balance, we will be able to clear the lung fluid and we'll able to manage it. Yeah, this is a next scenario.
So we now have the patient here. See, if you want me to do any settings changes, if you want to look into the alarms, you can actually prompt us. You are getting some alarm now.
Can you switch it?
You want me to do anything? We are getting some alarm. Sorry. You want to increase the flow? So he's saying he wants to increase the flow. He says pressures are low.
I think the as far as the ECMO is concerned, if the flow is around say 3.5 liters or so, the map of around 60 is enough because we go by map because a continuous flow. So around 60 pressure should be all right. So you are having a thing and you are having a map of around say 87 with a systolic of around 87 and diastolic of around 81. What is the pulse pressure you aim for in an ECMO patient? Any idea? What is the pulse pressure? It is the difference between the systolic and diastolic. That should be minimum 10. It means it is properly ejecting out. If it is going to be less than 10, the ejection is not proper. The LV is not able to empty the blood, whatever it comes to it. Any idea about that? Okay. So the pulse pressure is somewhat low here. We need to have a higher pressure. What is the problem in having a low pulse pressure? Or else LV is not ejecting means what we are going to face? What are the problem we are going to face? Any idea? Ejection? A dysfunction is there. What are the complications will happen? If the blood is going to stay in the LV for long, it can produce clots. So blood clot can happen. If the LV is not ejecting properly, then the left atrial pressure will be higher and the pulmonary edema can happen. So another possibility is there is LV distension, the heart is not going to recover. So we are placing the V ECMO means only the aim that the heart should recover. With the distal LV, the LV is not going to recover. So there are 3 points to be considered here for a distal LV. One is heart will not recover. Second is there is a significant pulmonary edema where it will hamper again the recovery. Or else the patient may develop blood. There is LV blood clots. When the LV is going to eject, the blood clot is going to go to the brain and is going to cause stroke. So these are 3 major components. So we don't want the LV distension to happen. So first thing is LV distension means we may have pulmonary edema on this. Let us look into the ventilator monitoring. Ventilator. So this is a ventilator setting. Here there is a high peak airway pressure. With the tidal volume around 440 only, the peak airway pressure is somewhere around 52. That is very significant. So what are the other investigations you want to do to prove that the patient is having pulmonary edema? What are the bedside tests you will do to prove or disprove the pulmonary edema? When there is a pulmonary edema, yeah. Chest X-ray you have?
Yes, sir. We are getting the X-ray for the patient.
So this is chest X-ray, full-blown congestion is there. And other bedside, what you can see is you can see the pink frothy sputum in the ET tube. So you can apply the suction and get it out and increase the P. So at this situation, what you are planning to do? So profuse foam, pink secretion are there. These are all confirms that the patient is having a pulmonary edema. So the problem is the LV distension. Is there any other way to confirm it? Echo. That's very good. Do you have echo image?
Yes, sir. I'll get that.
Oh, there is echo image. What do you see here? Sir, you can see a globular LV distended and also stagnant blood here. It is not emptying properly. There is a stagnant blood. Another important thing you need to see is this is the aortic valve. It is not opening properly. So there is a stagnation of blood in the root of the aorta also. So if you leave like this for long, clot can form. There is a misconception that if the patient is going to be on heparin, the clot will not form. No, like the clot will form after a few hours. Like ACT, normal ACT, what we say is around 120. And with heparin, we are going to maintain 160 means. It means activated time at 160 it clots. So here also, if you keep a higher ACT also, after a few minutes or few hours, it may clot. So don't have the misconception that the patient is on heparin, the blood will not clot. No, like if the patient blood is not going to flow, then it has a high chance for clotting. So what do you want to do here? Yeah, we can change the inotropes. Before that, anything? LV distension can happen in 2 aspects. One thing is increased flow, return to the LV, increased blood in the LV, and LV is not able to empty. So why as you said, why the LV is not empty? Because it is dysfunctional. So inotropes will be helping. That is one choice. Second thing is we don't want this much pressure of say around 80 or something like that. So if it is going to be like a higher flow, high pressure, the LV may struggle. The struggling LV may not empty much. First, you can decrease the flow and see. And as Sir said, we can add some inotropes also to increase the thing. So can you reduce the flow?
Yes, sir. We are around 3,100 RPM now, giving a flow of 4.5, reducing slowly.
So you can reduce it to 4 and see what is the value. 4.5 to 4.
Okay,
I
sir.
think it is reducing to some extent. Now also the pulse pressure is not that much, 70 and 73. Can reduce the flow further to around
Further reducing, sir?
3.5.
Okay. 3.5 liters, sir.
So the pressure is somewhere around now also 74 and 69. Now the variation is around say 7 or something like that. It's better than before, but still it can be much more higher. Reduce it to 3.2.
Coming down to 3.2.
So it's not fair to reduce beyond this because the patient may need this much flow. So we are not able to achieve the wanted pressure, pulse pressure by reducing the flow. Then next step is we can increase the inotropes. Patient is on what are the inotropes patient is on?
Loading in, sir.
So a drug of choice in cardiac dysfunction is one is dobutamine, and then milrinone and adrenaline. These are things can increase the contraction. So a patient with low blood pressure is better to start with dobutamine and then go for adrenaline rather than milrinone because of the profound dilator and the blood pressure may fall. So patient on inotropes, patient is on dobutamine. It's only around 2.5 mics. Then increase it to 5.
Increasing to 5, sir.
So the pulse pressure is around say just 10. Ejections are better, but I like to keep some more pulse pressure to be on the safer side. So for example, say 12 or so rather than 10. So can I increase it to 7.5?
Further increase to 7.5, sir.
It's not increasing that much. So let us see whether the aortic valve is opening or not. Can I have an echo?
Doing an echo.
There is no stagnation of blood that I can say here. I think it's not moving. So what we expect is there is no distension of the LV and there is no stagnation of blood flow and aortic valve should open properly. Then if that is going to happen, then the aim for which we are struggling is achieved. So we'll stop there. So here there is no obvious stagnation of LV. You can see here. And aortic valve also, this is aortic valve and there is no stasis of blood. So I think there is a problem and they are not able to move it. So usually like there will be a well opening aortic valve and we'll stop there.
Explains.
Yeah, few seconds it is moving and let's see. Okay, if it is going to be like this, we are happy. In spite of sometimes increase the inotropes, the things will not increase. Like our idea is to keep the inotropes as less as possible. There is no point in keeping the inotropes of adrenaline of around say 10 or so on an ECMO. So if you are going to keep the dobutamine to the higher level and also after starting adrenaline at a very small dose, if the heart is not going to improve, what are the things you can do? How you manage LV distension? What is it? Yeah, elastics and other things. So, but yeah, we can do the diuretic and then that will increase, reduce myocardial edema also. It can increase the cardiac contraction. Then, what are the ways you can bend the LV? Oh, okay. So this and all we have discussed, I think so. Pulmonary edema, blood clots and all. Proceed. So cause of LV distension is source of blood in the thing. So whatever you are sucking out the blood through the to the ECMO, the remaining blood enters the heart. That they are not able to eject. So that is accumulating inside the heart. So main source of LV distillation is blood that escapes the suction by the ECMO machine. Next. That is a main cause. Other causes are bronchial circulation, blood can reach, or Thebesian vein can reach, or else aortic regurgitation can also happen. Before initiating ECMO, you have to prove that there is no aortic regurgitation. There is no doubt about it. Next. Or else poor concurrently and high afterload. We dealt with these two, it is not improving. Then we have to achieve a negative balance. So by CVH or medical management or reducing the ECMO flow, there is another option, we have done it. Next step is IABP. So if you place the IABP, that increases the coronary circulation during the diastole. During the systole, it produces a negative suction and reduces the afterload. With these two methods, it can reduce the distension of LV, right? So in spite of placing the IABP, the thing is not reduced. Then if available, the facility is available, the impeller device can be placed, where artificial device is placed into the LV, where it sucks the blood from the LV and gives to the aorta. And next, impeller is quite costly, somewhere around 20 lakhs or so. Most of the people are not affordable, and sometimes it is not available also. So instead of going to this method, we actually go for LV venting. LV venting can be done by thoracotomy. Usually the enlarged heart, you are seeing the pulse pressure, like apical impulse, you'll feel in the fourth intercostal phase, just below just lateral to the midclavicular line. So if you place your finger there, you can able to feel the heart. So make a small incision there and place a vent there and then drain the LV. That is the best way to empty the left ventricle. Go for the next slide. Next slide.
This IABP you'll put from the another limb.
Other limb. Left femoral artery, we are cannulated. We'll cannulate the right femoral artery, the IABP, and then take it forward. Mostly not. That is only say around 19 French or something like that. That is 6 millimeter only. The diameter of the aorta is somewhere around 22 or centimeters. So passing a catheter, IABP will not be an issue. So impeller main advantage is hemolysis. Next. Next. Surgical option wise, I don't know whether you have listened. This is a nipple, a small incision made, and place a LV vent in the LV apex. Next. Connect that to the drainage limb of the cannula. That is venous side of the cannula. So there will be a suction force and it can empty it to the ECMO. And the LV will be emptied. Next. Yeah, this is the port. This is the incision what we have made. This is going into the LV apex and draining the blood. That is connected to the drainage limb, and the LV will be empty, and we'll monitor the patient. Like for however long the echo contracts. By echo, we will see the LV also. And LV, once it start contracting, then we will gradually reduce the flow here by again the tube occluder, and then keep some blood in the LV and see how it is ejecting. And once it is recovered well, we will remove the LV vent. Yeah. This is the LV vent. Yeah. LV vent, actually, why it is dark means there is a reason why we are placing. There is a pulmonary edema. Pulmonary edema, there is not oxygenating, so it is coming out. So sometimes when it improves, as you said, the pulmonary edema is going to reduce or something, then it will be bright blood.
By seeing that also you can decide the pulmonary edema has come down.
Pulmonary edema is it.
What I notice is that is dark. As the pulmonary edema subsides, that will change color.
The bright color.
Direct access.
There is a one way we can see that the pulmonary edema is improving. So we are going to drain like that. Next. So if you are going to place a larger cannula here, instead of placing say 16 French, the LV apex, we can place up to say around, for example, 21 French. And then we can convert this to short-term LVAD. If the lung improves, then what we can do is we can actually remove the femoral venous cannula. So the LV vent is connected to the femoral venous cannula, right here. So when the lung improves, we can just disconnect this and convert this as a draining cannula and this as a return cannula, and then this oxygenator can be removed. So anticoagulation may be even more better. And the main problem in the circuit, ECMO circuit, is the oxygenator that causes more hemolysis. And if you remove that, then you can convert it to the LVAD. So short-term LVAD. If heart alone is a problem and lung has improved, so no need for the oxygenator, we can remove it by this method itself. If you anticipate that, place a higher diameter cannula. Can you understand? Not able to. Okay. So here the cannula what is placed usually is 14 French to decompress the LV alone. So if you think that the patient may need a long-term support, then placing the patient on ECMO is quite risky. Rather than we can, if you remove the oxygenator, then with the centrifugal pump alone, you can place it, get the patient to around say months together without much complication. We anticipate that, place a cannula of around say 19 French or 21 French here, and then that alone can be there, and this venous cannula we can remove it once the lung has improved. So suction will be from here, and delivery will be in the axilla or in the femoral artery, and it will be like only supporting the LV. So VAV can be converted into like from the LV to the aorta. That support can also be given. There is all quite advanced, I think so, right? So far, okay. Two main scenarios in a VAV ECMO or Harlequin syndrome. You need to identify and treat it. Next is the LV distension. We're able to manage these two, they'll be all right. Other minor complications like initially there may be some flow reduction where you have to give some volume to keep the flow, or else some inotrophs may be like patient may be vasodilated more. At the time, you may need to add some NORAD in the first few hours. Those things are routine, or else some problem in the oxygenator, we need to deal with the oxygenator. There are routine things. As far as VA ECMO is concerned, there are two main things you need to anticipate. This is one is Harlequin. We have seen how to manage that. Other is LV distension. Once you have done that, you need to wait for the recovery. As in any cases, like bleeding and infection or a major complication. So after placing the ECMO, don't relax. That is the time you need to aggressively act on the patient and think about when you're going to wean the patient successfully rather than relaxing. So once everything is stabilized, look for urine output, good urine output and lactate, and those things are fine. Then start reducing the inotropes. Whatever inotropes you have, first get down the inotropes first. There is no point in reducing the ECMO flow with the high inotropes. So as soon as the ECMO is started, try to get the inotropes to minimum level or switch it off as quickly as possible. So there will be a recovery. This is a more physiological way of keeping the blood flow rather than with the inotropes. Inotropes causes vasoconstriction and decreased blood flow. Even though you have good blood pressure, and there will be a decreased blood flow to the organs because of vasoconstriction. So if you have a good ECMO flow, then get down the inotropes or else to the very, very minimum level, or else even switch it off. Then once you have done that and patient is stable with a good lactate and good urine output, then you come down on the ECMO flow, right? Any questions till now? Okay.
Something about the P1, P2, P3 pressures.
Yeah.
How to
So
adjust them?
normally the pressure in the ECMO machine, as such, we monitor the pre-membrane pressure and post-membrane pressure. Okay. So normally there will be a slight variation between what is P1 and P2 and P3. There are three main pressures what we monitor. One is monitoring the venous pressure. The venous pressure in the venous limb, this pressure. So this is the blood that comes from the patient to the pump. So pump rotates and sucks the blood. So it will be negative pressure. So normally around say 70, minus 70 is fine. More than other, like it should be more than minus 70. More than minus 70 is minus 50 or minus 40 or something like that. It is going to go less than minus 70, like minus 80 or minus 100 or minus 110. Then there will be a chattering of the blood, and also there will be a lot of hemolysis, and the flow you can't maintain it. So that pressure should be maintained above minus 70, right? That is pre-membrane, pre-pump pressure. That is called as pre-pump, before the pump pressure. That is P1. Next is the P2. From here, you have to move that side. From this is the pump, it goes here, goes here. Here, from here, it will be a higher pressure. The pressure is mounted here and it is getting transferred here. This pressure will be higher pressure. This is the before the oxygenator. It is called as pre-oxygenator pressure. And after the oxygenator, this is the post-oxygenator pressure. So we'll be monitoring this as a P2, and this is P3. Pre-oxygenator pressure is around P2, and post-oxygenator pressure is P3. So normally the trend in the P2 and P3 is very important. You monitor the pressure in the P2 and the P3. Normally the difference will be around say less than 30. And if it is going to go up, then it means there is some resistance offered by the oxygenator, and there is some blood clot formation in the oxygenator. So if the trend is going to go gradually climb, for example, today you're seeing 30, next day you're saying 40, then you have to suspect there is a clot formation in the oxygenator. You can increase the heparin first and see whether it is coming down or not. Or if it is not coming down, it is going to touch something like say 70 or so. Then look for hemolysis or post-membrane gas, whether it is low in the saturation or something like that. If there is a significant hemolysis or the fibrinogen level drops or your oxygenation, post-membrane gas is less than 200, then that's the time we need to change the oxygenator. So P1 pressure actually tells about fluid balance, how much the system needs the fluid. So that can be monitored. The P2 and P3, the difference in pressure will give you an idea of say whether there is a clot formation in the oxygenator or else guides us whether the oxygenator to be changed or not. So that's where the pressure are useful for us, right? Are you able to understand, sir? Post-membrane pressure. So difference between P2 and P3 is important thing. Difference between P2 and P3 should be around 30 or so. That is more important. And generally, like if any isolated P2 or P3 is going to go more than 300, chance of blowout is very high. Where the tubing connection is there, that can come out. So always better to keep the pressures less than 300 mmHg. More the pressure, then the tube can get disconnected. So that's why we are monitoring these pressures. Okay, shall we move on to here? Fine. Proceed.
Slides, please.
So by echo wise, you are having a very good contractility. The heart function has improved, and your lactate and urine output was fine. Then the flow in the patient gradually start reducing it to around say if the flow is going to be around 4 liters, come to around 3.5 and leave it for 2 or 3 hours and repeat a lactate, and there is no change. Gradually reduce by 500 to 500 till you reach around say 1 liter flow. And with 1 liter flow, if the patient is going to have a good lactate for say 2 to 3 hours, get him to the theater and switch off the flow and monitor by TOE. If the contraction and other things are okay, then you can go for decannulation and then observe. At that time, if you are switched off the inotropes or else the inotropes are in very low dose, then you can hike up adrenaline or dovitamin, whatever the center's preference, to about minimum level and then come out. That 0.5 liters to 1 liter of blood flow, whatever we are reducing, that can very well be taken care of by the inotropes. So we need to get down. Usually after decannulation, we don't discard the circuit. We keep the circuit running at least for a day or two, so that if at all the patient is going to have any problem, then we need to recannulate the patient. So decannulation wise, venous cannulation, if you both are introduced percutaneously, the venous cannula can be just pulled out and compressed. But arterial cannula, always we have to go to the theater, open the patient, and then suture the artery to prevent pseudoaneurysm in the future. Okay? Any questions, doubts? Element during the theater time. Yeah. Theater we remove. At the time, I think the same thoracotomy incision. You can get it up and then remove. When you incise and then place the pericardium, stay suture and pull it up, LV nicely comes up. See. That too, when you are going to remove it, clamp the LV vent and allow some blood to the heart. That will get the LV apex towards you. Then you can easily repair it and then put it inside and then close the patient.
Our cardiology friends were putting a big cannula for stenting out or thoracic out. They make a big hole in the artery, still they just compress it by.
No. What you're talking about is transcutaneous aortic valve replacement, I think so. For that and all, they are placing a significant French. While before the placing the French, they are placing that whatever device they want. The device size is also equal to the ECMO cannula. But before placing that, they introduce one device called as preclude. That preclude device, they will tie it once the thing is removed. So if you place that, you can do like that. But that is usually okay for a short term, something like a few hours, 1 or 2 days, and then that can be tied. But for ECMO and all, it is going to last for say 7 days or so. The sinus tract and all can be formed. If you do the preclude, chance of cut through and other things are very high. So better to avoid it. Yeah. While removing the cannula, first we'll identify both femoral artery, proximal and distal side, and then place the clamp, and then put a Fogarty inside the distal thing and remove it, proper embolectomy, we need to do it. And make sure the good gush of red blood is coming, and then place it on the proper repair of the tooth. Need to be done. So usually we take the help of our vascular colleagues. They'll do the job.
Our part, it's the view only.
Yeah,
There's no separate
Like
vascular.
I was trained in Jipper and all. We are doing by themselves. Now here we have the luxury, so I'm doing it. So we are handling the aorta and all. We can handle the femoral artery and also. Should not be a problem at all. Any questions? Shall we wind up? Thank you. So I think you can assemble in Hall A. We have a lunch day. What is the time now? 11:10. So there'll be a lunch to be provided in Taj Wellington around 12:30. Who is interested can go there, right? Thank you.